Aspirin. Aspirin is now less commonly ingested in overdose. Occasionally, poisoning follows the topical application of salicylic acid in keratolytics or the ingestion of methyl salicylate, oil of wintergreen. Its primary toxic effect is to uncouple oxidative phosphorylation. Presentation. The typical features of moderate salicylate toxicity are sweating, vomiting, epigastric pain, tinnitus, and blurring of vision. In adults, there is also an early increase in RR, causing alkalosis that precedes the later development of metabolic acidosis. Children are more likely to develop an early pure metabolic acidosis. In severe overdose, acidosis reduces the ionization of salicylic acid, which enhances tissue penetration. In the CNS, this presents as agitation, tremor, and fits, coma, and respiratory depression. This also decreases renal salicylate clearance. Complications. Metabolic acidosis. Pulmonary edema, non-cardiogenic, ARDS. ARF. Abnormal clotting due to hypoprothrombemia is very rare. Significant GI bleeding is surprisingly infrequent. Prognostic features. It is important that plasma salicylate concentrations are interpreted in the context of clinical features and the patient's acid-base status. Significant toxicity is unlikely at peak salicylate concentrations less than 350 mg/L. Salicylate concentrations of 500-750 mg/L represent moderate toxicity, and greater than 750 mg/L, 5.4 mol/L, severe toxicity, but severe features can be seen at lower salicylate concentrations in patients with metabolic acidosis and in children, less than 10 years, the elderly, greater than 70 years. Severe metabolic acidosis is associated with a poor outcome. Management. Take blood for UNES, PT, and salicylate, and paracetamol, concentration at 4H after ingestion. Repeat every 3-4H in symptomatic patients and in those with a salicylate concentration of greater than 350 mg/L later to assess continued absorption, as tablets may adhere to form large masses in the stomach or some preparations are enteric-coated. Activated charcoal should be given if greater than 125 mg/kg of aspirin has been taken in the last hour. If after 4H, salicylate levels are continuing to rise, a further dose of activated charcoal may be given to patients to prevent late absorption. Check ABGs to assess the acid-base status. Mild or moderate salicylate overdose requires only PO or IV rehydration, with particular attention to KN supplements. Patients with significant clinical features and a salicylate concentration of greater than 500 mg/L should be treated with urinary alkalinization to get urine pH to 7.5–8.5. Regimens include 225 mmol of sodium bicarbonate, 225 ml of 8.4% over 60 minutes or 1.5 L of 1.26% over 2H, repeated as necessary to keep the urine at pH 7.5–8.5. Further boluses of bicarbonate may be required in patients with a significant base deficit. This may cause hypokalemia, which will limit urinary alkalinization. Check serum KN levels every 2–3H. Forced alkaline diuresis is no more effective and is potentially dangerous. Hemodialysis is indicated for patients with severe poisoning. A salicylate concentration of greater than 900 mg/L, 6.51 mol/L, and particularly if associated with persistent or progressive acidosis, deteriorating level of consciousness, convulsions, non-cardiogenic pulmonary edema, and renal or cardiac failure. Pulmonary edema may indicate either fluid overload or increased vascular permeability. This is a bad prognostic feature in salicylate poisoning. Admit to ITU and monitor cardiac output. Non-cardiogenic pulmonary edema may require CPAP or mechanical ventilation, and these patients are also likely to require hemodialysis.